or so, despite our improvement in perinatal care. I have no conflict of interest in this presentation, and my objectives of this talk are fivefold. One, I will briefly explain the basic anatomical development of the brain, so-called neurogenesis, because as Junaid always reminds me, I always like to talk about the pathophysiology first, because if you understand the physiology, then you understand the pathology, and then you understand the treatment, because the treatment is to put the pathology back to physiology. I will describe the functional development of the brain during perinatal period in some detail, because that is where we as neonatologists need to understand what we do and how it affects the developing brain. So I'll talk about neuronal cell development and migration, development of connectomes, i.e. connectivity of these neurons, and development and importance of the functional networks, which we need to form all the time to have a good functioning brain. And I apologize to some of you who may have seen some of these slides in my earlier presentation. I'll then talk about the effect of preterm birth and environment on the developing premature brain, how our practices and strategies impact the process of brain development, and lastly, I'll just show you our neuroprotective bundle, but there are many neuroprotective bundles, and what I'm going to show you is certainly not the last word or absolute, but it is one of the neuroprotective bundles which I will describe. So let's start. For us, there is a debate always whether heart is important or brain is important. For us, human brain is everything. If you look at the brain size, of a human brain is the largest amongst all mammals compared to their body weight. If you look at a rhinoceros, which may weigh 2,000 times more than my grandson, but my grandson's brain is 200 times larger than the brain of a rhinoceros. And it is larger because it is more dense, it has more neurons, it has more connectivity, it has more myelination composition, and has greater plasticity. And to our nearest relative, which is the ape, if you look how dense our cortex is compared to the density of an ape. So our brain is what we are, and that is what everything is about. And therefore, it becomes an extremely, extremely important organ in the body, and particularly during its phase of development. Now, brain develops in a very structured manner. And there is these developmental stages, neurulation, that is formation of the brain itself, the structure, cortical development, along with neuronal cell development. Then the neurons need to migrate to get to the right places. First, the neurons need to be there, then they need to migrate to the right places. Then they need to be myelinated, because if you have the neurons, but if you're not able to transmit the information at a particular speed, then you're not working, your brain will not be working so hard. So there's myelination. And then there need to be connectivity, that the neurons need to connect with each other so that they can transmit information. And at the same time, there is the development of neurovascular units, which direct the blood flow to these developing neurons. And that is why the blood flow to the brain is early on is very high, because the neurons need a lot of nutrition coming from the blood vessels. And last but not the least is apoptosis. Because there are huge number of neurons being formed, some are surplus and some are useless, and they need to be pruned, and they need to be broken down, and then new neurons need to be developed, which are useful, and that gives you the plasticity of the newborn brain, which is lost in people like me at my age. Now, these things are, for description purposes, it's very nice to put them in order of, but actually they are happening at the same time. But the problem we are facing as neonatologists is that if a baby is born preterm, and this is the blue shaded area shows the preterm area, then a number of these developmental stages may be affected either completely or partially, or get array and not develop normally. So, and this process, this dysmaturation of the brain during the preterm period is what we are going to talk about. And this is the period when we are dealing with the baby. So it is important to remember that the brain is forming, it's shaping whilst we are doing whatever we are doing or not doing. On top of that, there is, of course, the vertically transmitted maternal modulators, exosomes, as they are called, which affect newborn brain development. If the mother is stressed, mother's maternal microbiome, mother's circadian rhythm, and that is extremely important because you might remember from your epidemiological studies, ladies who do shift work, they have a much higher incidence of developing, giving premature birth. Medication, inflammation, we all know about. Steroids, I'll talk about. And then there is a little bit of microchimerism, which is not important, but is now a subject of great interest. And there may be other factors which also affect the brain development in the newborn. So let's come to the brain development. The brain plate forms on the 13th day of gestation, and from there on, from about 11 to 12th week of gestation till 34 weeks, the brain grows very steadily, as I can show it growing here. But suddenly what happens at about 34 weeks, it seems there's a kickstart to the brain, and between 34 and 40 weeks of gestation, the cortical gray matter develops, brain size and volume increases threefold in the surface area. That is the maturation of the cortex of the brain, about 4 to 6 folds. It is much faster in girls than in boys. But importantly also, something which we do not pay much attention to is the cerebellum. The cerebellum grows about 7 folds. And so the importance of cerebellum, which this little part of the brain we tend to forget, but is very, very important. And that is the reason why it grows very, very fast. And if you ask a pregnant woman, when she feels the kicks of the baby, the kicks are very sudden before 34 weeks. The kicks are much more frequent, but much more organized after 34 weeks. Now, all this development and growth is dependent on the interaction between genetics, the epigenetics, the exosomes of the mother, and the environmental factors. And we are responsible for the environmental factors, while mother is responsible for the epigenetic factors and the genetic factors. Now, this is the same thing which I'm showing you again, but just for our younger colleagues, if you look at the brain, it starts gray with a two-beam sort of appearance, but between 34 weeks and term, the brain becomes like a walnut. The reason being that there are a lot of sulci and gyri, and the brain folds on itself and becomes much more denser. That is important, the cortical development, but it's far more important is the white matter development, and 60% of white matter develops from 34 weeks onwards. And if you look at T1 weighted images of the brain appears earlier on at 23, 24 weeks to be a collection of gray collection. It's much more grayer than it is, because that is cortex. But as the baby matures, you see more white and white appearing, and that is the development of the white matter. And if you see how the color density has changed from gray to mainly white, because there is a huge development and very rapid development of white matter. The white matter, of course, is what transmits information from various cortical areas. So what does this preterm birth mean for a developing brain? The preterm baby misses out on this surge of cortical surface development and cortical volume development. So earlier the baby is born, the smaller the brain size, the smaller the weight of and volume of the brain. The cortical surface is smaller, there's less sulci and gyri, reduced sulcal depth, and the white matter is reduced. Now, the poor preterm baby suffers from a double whammy, because that has been shown by Sentry and colleagues that when you give intensive care to these very preterm babies, they have an impact on brain development. And so it has a negative impact, and therefore it again affects the maturity and development of brain. So here we are dealing with preterm babies who have potential of having a small brain, and then we have to give them intensive care because that's how they can survive. That has this double whammy effect on the developing brain. So let's start with neuronal development. Now, it's important to remember that the neurons develop from deep periventricular area and travel upwards towards the cortex of the brain. And this development takes place in ups and downs. And this was first shown by John Dobbing from Manchester in UK. And I was greatly honored that I was his SHO during this period when we did this research. And it shows that there is a very rapid growth of neurons during these critical periods. Now, you and I know, and those who are senior neonatologists would know, that if you get an injury or an insult during the critical period, the damage may be devastating. But a very similar injury during the resting period may not give you such a devastating injury to the brain. And that is why some babies who get injured have a much more pathological appearance and suffer greatly, whereas another baby with a similar sort of insult does not suffer that much. And that is because of the critical development period and the injury, when does the injury occur or the insult occurs. There is, of course, the sex difference also in brain development. And I just want to point out two things here. There is the difference in anatomy, in the cell number, cell size, and total surface area. We all know that female brain has much more cells, much more cell numbers, and the total surface area, though the brain is smaller in volume, has much greater surface area. But most importantly, when there is cell death and repair, the female neuronal cells die from apoptosis. That means they shrink and they collapse and die without upsetting or injuring the other neurons alongside. Whereas male neurons, when they die with non-apoptosis. That means they burst and they may injure other neurons alongside. So the injury which occurs in females is slightly different in pathological terms than in males. The neurons, of course, as I said, develop deep into the periventricular area from the neuronal stem cells, and they start appearing from the 19th day of gestation, and they travel upwards towards the cortex in about 3 stages. The first is an intermediate zone where the cells differentiate into neurons and glial cells. The astrocytes, which are accompanying these neurons, make sure that they guide these cells and repair them as the neurons travel upwards. The second stage is the most congested area of the brain and neuronal development. Here is the neurons differentiate into particular regional types, which will go to the frontal brain, which will go to the occipital brain or temporal brain. And here there is also the synapses of neurons starting to take place. At the cortical plate, the synapses have been formed, and there are lots of, and myelination is at full speed. But here is the networks are forming, and those neurons which are excessive to the need or surplus are then pruned out and are lost. Myelination is extremely important because it is the myelination on which the speed of the transmission depends. And that is why the younger the age, when we are born, young children have a much greater capacity to learn and repeat things much more frequently than at my age. I cannot hardly remember what I'm talking about in 10 minutes ago. And therefore, myelination is extremely important. And myelination is not only dependent on long-chain polyunsaturated fatty acids, which are essential, but also some exosomes and glycosylated protein, which adhere to the neurons and guide the exons to the particular synapses formation. And these, unfortunately, are low in the very preterm infant. And how can we help that? We can help that by providing more neurons, by delaying the cord clamping, and early breastfeeding. Early breastfeeding has been shown to increase cortical mass, cortical volume, surface area, particularly of the core brain, that is the thalamus and caudate nucleus, which are responsible for our sensory, motor, and conscious and higher executive function. And here, as you can see, the more the duration of breastfeeding, the greater the content of myelination. And just recently published paper, which is fascinating, it shows that newborn with moderate to severe HIE undergoing therapeutic hypothermia have decreased levels of neuronal fatty acids essential for myelination, and hence the current very vigorous debate on what to feed, how quickly to feed, and when to feed babies undergoing therapeutic hypothermia. In fact, there's more and more evidence that they should be fed breast milk as early as possible. Now, with increasing gestation, what happens is there's more myelination taking place, and they transmit information. And to me, it was a surprise, but it's about 150 miles an hour. So the information is being transmitted at a very, very rapid pace. The more the premature babies, because they have less neurons and less myelination, and they have a slower speed of information transmission. How does that impact on the baby? Well, the preterm infants often perform poorly on complex problems in school and later life, which we know that because the information transmission is not at that rapid speed. Billions of neurons, as I said, are formed and many are not needed, and they are pruned, they are cut off. And the natural apoptosis, which often is deficient in preterm infants, leads to a traffic jam because there are too many neurons which are not required, and they're trying to connect with each other, but it cannot because there are no connections to be formed. And what is the impact of that? Is preterm infants have a greater frequency of developing autistic spectrum disorders because they get confused with a large number of neurons which cannot form synapses. Now, that is the natural way of apoptosis, and but of course, what we do and a lot of medications which we use induce apoptosis, particularly within the white matter, and so the white matter is disrupted. And the greatest culprit of doing this are the anti-seizure medications like phenobarbital, Keppra, and lamotrigine, etc. They are the worst in trying to giving the apoptosis within the white matter. And in one of the presentations earlier in this module, it was suggested that anti-seizure medication should be continued after discharge. And in fact, that falls well within the normal range, in the sense that there was a analysis in 14 units in United Kingdom, 308 babies, and they surveyed these units, and between 13 and 100% of babies were discharged on anti-seizure medication at discharge. But there was no difference in their score or in having future convulsions or developing epilepsy. But what is important is that that same survey found that about twice the time there was a greater disability or death at 18 to 14 months in babies who were given anti-seizure medication beyond discharge. And in another study which had been published earlier showed adverse neurodevelopmental outcomes after exposure to phenobarbital and levetram for treatment, and the result was increased incidence of cerebral palsy to 3-fold and decreased Bailey score by 8 and 9 points. This has led to the current International League Against Epilepsy guidelines published earlier this year, recommending that anti-seizure medicine should be discontinued before discharge, regardless of MRI or EEG findings. And that's very important message to convey to our colleagues who treat babies who have convulsions or seizures during neonatal period. The next stage, which takes place with the neurons after developing, is they need to go to the right places. And so they go to the sensory motor cortex from 31 weeks onwards, and to the parietal cortex also from the 31 weeks onwards, which have these functions. But what is much more important is from 34 weeks onwards, these neurons migrate to the prefrontal cortex. As you know, the prefrontal cortex is responsible for our executive functions of decision making, behavior, and personality. And that is one of the reasons babies born before 34 weeks or so, or around that period, have a much higher incidence of behavior and personality problems, as I will show you in a slide later on. Then when these neurons get to the right place, they are like dots. They need to connect the synapses, because that is the only way knowledge is transformed from information to knowledge. And so the neurons need to connect to transmit information. Without connections, information cannot be transformed into knowledge. And of course, only neurons that are connected and functioning and survive are used, and others will die from apoptosis. So the more we use our neurons, the better it is. Otherwise, as it is said, use it or lose it. If you don't use your neurons, you will lose them. So it is important for synapses to form. Now, these synapses are now connections are formed. Now they need to connect with other connections, so-called through connectomes. There are about nearly 150 billion neurons present and forming networks throughout what is called connectomes. There are hundreds of networks: visual, auditory, sensory, language, attention, and so. But what is important to remember, and I hope you will remember this, that these networks have two bases. One is a task positive network, and the other is task negative. One stimulates you to do that task, the other tries to inhibit you, and there is a balance. And that balance is made sure through a connectome, through one center office, so to speak, which says, do this or don't do this. And that connectome is there. So there is a single connectome, and I'll tell you why it is so important in the functioning of these networks. Because these connectivity and networks contribute to long-term outcome in baby, and this is particularly true for babies who are born growth restricted. And you can see the network distribution and connectomes are much less in the IUGR baby. And that happens, as you know, the connectomes, of course, in term babies are quite a lot, preterm baby infants less. But what happens in HIE or other insults where there is hypoxia, these networks and connectomes are disturbed. Now, what I said earlier is important. Then you have the task positive network, the task negative network with one connector. But if for some reason, and particularly in preterm because of lack of maturity, there are multiple connectomes. So these two task positive and task negative networks are connected by multiple connections, and that causes confusion. And that is one of the reasons thought to be that these preterm babies have a higher incidence of autistic spectrum disorder, because they have too many messages coming at the same time. And this has been shown by Jackson and Johnson and others, that babies who are born preterm, and these are green lines are 24 to 28 weeks, red lines are 29 to 30 weeks. This is the baseline. Nearly all these babies have greater psychiatric disorders, psychotic disorders, organic and stress-related mood disorders, and much higher incidence of sex. So there is the impact of all this on the brain development of preterm birth are significant, whether we do something with them or not. But of course, if we try and avoid disrupting the brain development, then that will reduce the incidence. So, okay, let's sit back. I've given you a reasonable amount of science to think about. Let us come to the practice and the art which we are born and what we actually do, the art and science of neonatal practice. I'm not going to talk about the talks which have been elegant talks which have been given before, except to point out once again, which I pointed out to Naveed in his presentation, that whenever you do ultrasound, please do use the mastoid foramen. Here's a beautiful case presented by Linda de Vries, who's the doyen of cranial ultrasound. Normal sagittal view of the ventricles. If you only did that, you will say this is a normal baby. But when you looked at when she used the mastoid foramen and looked at the cerebellum, here you see punctate hemorrhages. And so one is quite often surprised when you do an ultrasound and it says normal, and then the baby suffers from neurodevelopmental impairment. So it is important that we need to look at the cerebellum every time when we do the ultrasound. So, pregnancy. And some things which we can, some things which you can't. Of course, mother and baby are a dyad, and what mother does and what happens to the mother affects the baby. And prenatal exposure challenges may lead to lifelong neurodevelopment. For example, if you have the gut, the microbiome, the circadian rhythm, infection, stress, glucocorticoids, and various other factors that will affect the fetal brain development, and then that goes on to, in childhood, may cause increased risk of neurodevelopmental disorders like ADHD and ASD, as I pointed out. And of course, this may go on through epigenetic changes to adolescence and adulthood. So pregnancy is very precious, and the effect of what the mother has on a newborn developing brain. We give them antenatal steroids. And of course, the National Institute of Health consensus statement about 20 years ago stated that antenatal corticosteroid therapy is indicated for women at risk of premature delivery with few exceptions, and will result in a substantial decrease in neonatal morbidity and mortality, as well as substantial savings in healthcare costs. But very astutely, they asked, but what about neurodevelopment? And recently, only a couple of months ago, a paper was published by Ninan in BMJ, where they looked at 1.6 million infants whose mothers were given antenatal steroids. And in fact, 48% of mothers who were given one dose of steroids, 48% of them went on to deliver at term. And I recently had on the academic group, there was discussion about second and third therapy of antenatal steroids. In fact, if you look at the long-term mental and behavioral disorders, they have a much higher risk of having mental and behavioral disorders, those babies who are, those mothers who receive more than one or two courses of antenatal steroids. And this has been borne clearly by the very large Finnish study, whole population study, showed that the behavior disorders are double in babies who have been exposed to antenatal steroids, and particularly in preterm, it's about 45% more than the term infant. Those infants who are delivered at term when they have been exposed to antenatal steroids. So there, yes, if I can go back, the antenatal steroids are good, bad, or both. One doesn't know, but certainly one should be very careful in repeating the courses of antenatal steroids. Well, I just wanted to put this slide up just as a side, really. There's a very interesting study only published 2 months ago in Cell, which shows that the maternal vaginal microbiome affects the neurodevelopment later on of the newborn baby. And they looked at the ASQ score at 6 months, and it was significantly higher in vaginal births. And that I just point this out that, of course, vaginal birth is more important than C-section, and I'm concerned about the rising rate of C-sections in Pakistan and other developing countries. I just wanted to raise that issue. So we've done with antenatal. Now let's come to the what we do. I mean, can you imagine booking yourself into a hotel room, paying 50,000 rupees or 100,000 rupees a day or night, being put in a room which is illuminated, which has got noises coming from elsewhere, lights coming from elsewhere, you're sleeping on a hard sort of mattress, and sometimes the people from the hotel come and prick you and wake you up and make sure that you're awake, and occasionally switch off the lights a little bit. And would you be booking in such a hotel to stay paying 50,000 or 100,000 rupees a day? But that's what we do. We put these babies in incubators. Quite often the neonatal units are illuminated. There's a lot of noise happening within the incubator because of the fan and the humidity going on, the heating, and then the noise of the crowd and the tissue and the people around and the alarms going on. And one of the things the reason I put this first before coming to other things, sometimes a couple of our colleague neonatologists do not feed these babies very early on. They are worried about necrotizing enterocolitis, they're worried about aspiration, but they don't think about the brain. And here is the brain, and the PET scan of a healthy brain and a PET scan of food-deprived brain. You can see how less the red active areas are. And of course, we all know that if you don't feed these babies, because these babies require much higher calorie intake, you get all these function of hypoglycemia, metabolic dysfunction, bacterial translocation, poor weight gain. And poor weight gain is epidemic in the sense that you get virtually all, if not all, majority of babies get extrauterine growth restriction. And if you see the evidence there is, both from clinical studies, that the less the weight gain, the greater the neurodevelopment and impairment in these babies. But now with diffusion tense imaging, we can see that the white matter density is reduced, and both in volume and in density in EUGR babies. So what we are doing by not giving them adequate nutrition, we are actually affecting the brain much more than the weight, which we all measure and talk about. But we do not think about the brain. For every 1 gram per kilo per day increase in growth velocity is associated with 2 points in language score, and particularly growth restricted babies, about 3.3 points in cognitive, and that may make a difference whether you become a politician or a doctor. So it's important that we make sure that we have good nutrition for these babies. And whilst these babies require ventilation, intensive care, and that is the period when we don't feed them very well, and you see that their brain development lags behind the normal. So their whole the question of giving them good nutrition, particularly during intensive care, is extremely important. And whilst I'm at nutrition, I just wanted to put this slide up because there was some talk about what TPN. Now, you remember the amino acids are functional for brain growth and neurotransmission and myelination. But what is important to remember is that preterm infants require higher intake of essential that is the essential amino acids, that is the body which produces those amino acids, and conditionally essential amino acids. These are the amino acids which body is unable to produce and gets from the nutrition. And so these, you need to provide them both kind of amino acids, and high or low levels of these amino acids lead to both structural and functional impairment. And the TPN solutions which are available are based on term human breast milk amino acid aminogram, and that is highlighted in the red, as you can see. Now, the most nearest to the breast milk aminogram comes are the prominent, and I have no shares in this, but I just wanted to name them as the quinine and the tofamine solutions. These are the ones which come closest to the breast milk, but even in them, sometimes they have very high some amino acids, and sometimes very low of these essential amino acids. But what I was very surprised, and Saeed very kindly provided me with the aminogram of the solution which they use in this hospital, and look at that, it really is very deficient in both essential amino acids and also in conditionally essential amino acids, and they need to relook at what amino acid solutions they are using. Some things which we practice all the time: heel pricks, putting IV lines, pricking these babies. And of course, we know that these, every time you prick the baby, every time you hurt the baby, you affect the core of the brain, the thalamus and the caudate nucleus. And Elizabeth Dudrin from Sick Kids has shown very clearly that the thalamus volume goes down, the more pricks you have, the volume goes down, the functional capacity goes down, and the ratios goes down. So it is every time you prick a baby, please remember that you're not only just causing pain, but you're actually affecting the brain of the baby. And what we do to reduce stress of brain, unfortunately, that doesn't help either. Morphine reduces cerebral volume, midazolam increases neuronal apoptosis in the hippocampus, paracetamol affects the endocrine system, and of course, Ventolin affects the network formation, glucose affects the basal ganglia. And so it is important that we make sure that we use these medications much more thoughtfully and carefully. And recent work has shown that hydrocortisone and dexamethasone, which you use to either hydrocortisone to treat shock and hypoglycemia and shock, whereas dexamethasone to treat for BPD. And this is the blue are control, the red is hydrocortisone, and the green. And you can see that nearly all these drugs reduce cerebellar diameter, biparietal diameter of the brain, have effect on corpus callosum, have effect on head circumference. So in summary, what I'm saying is nearly every medication we use has an effect either on the growth or function of the growing brain. And recently, again, published in the archives, shows that hearing loss in preterm infants increases with medications which we routinely use, gentamicin, vancomycin, furosemide, etc. And basically what it is telling us that, okay, 5 to 7 days of antibiotics increase the risk of necrotizing enterocolitis, but we forget that hearing loss in infants born between 28 and 31 weeks of gestation is 6 times more frequent than those born at term, and is seen in about 2% of survivors of babies who were born less than 28 weeks. And this has not decreased despite measuring levels and improvements of care. So we need to be very careful what we give, how long we give it for, and what sort of dosage which we are using. To wrap it up, as I said, I will give you some neuroprotective 6 strategies of neuroprotective care. This is ours. This is not written in stone. There are many, many neuroprotective strategies. Some have got hard evidence, some have got soft evidence. So there are about 5 neuroprotective. Hello? 5 neuroprotective elements of healing environment: light, smell, touch. And so we'll talk about that very quickly. And that is first and the most important is sleep. Now, I know how important sleep is to me. And as you get older, it is difficult to go to bed. And once you get up, then it's very difficult to go back to sleep again. But the newborn baby spends a great deal of time, about 90-95% of time asleep. By the time the baby is term, about 75% of the time to sleep. And sleep deprivation reduces brain size and plasticity, which is associated with lasting effects on learning and behavior. And so it is important to make sure that we allow these babies a good sleep cycle. And this is a minimum of 60 minutes. So we need to leave these babies alone in slightly not very bright, not very dark. You know, if you change from very bright to very dark, that affects the brain, that affects the melatonin levels. And so you need to dim the lights. You don't need to make it absolutely dark. And use when the baby is awake, that is the time to give caregiving. That is the time to do the procedures, whichever you want to do. The other is, how do you nurse them? And there is a debate whether you should contain them, as it is here, allowing them some possibility to move their hands towards their face and mouth, because mouth is the most sensitive area of the brain. And you may have seen intrauterine pictures of the baby sucking his or her thumb. And so mouth is very important, so they need to get to their mouth. But of course, in Japan, where the survival rates of 22-weekers and 23-weekers are very high, highest in the world. They, of course, do not do that. They actually tie the baby in an extended position. So I really do not know. We tend to do containment rather than restraint. The other debate, which is on the prevention of IVH and to maintain midline or neutral position and 30-degree elevation for the first 72 hours, that has been hotly debated. And in fact, there is little evidence to show that, but that has become part of our routine practice. What is important is to avoid excessive handling, because the more you handle the baby, the more cerebral blood flow changes you do. And so it's important to handle the baby very carefully rather than restricting on maintaining a midline position. But again, as I said, that has become common practice, but there is no robust evidence for that. I think it is important that when we handle the babies, sometimes our nurses are very busy and they come and quickly change the baby's nappies or do whatever procedure they have to do. But doing things quickly may be efficient, but it's very stressful for the baby. Baby does not like sudden changes. Just like me, I don't like sudden changes in life. But that leads to autonomic instability and leads to more apnea and bradycardia and desaturation. It's much better to hand both ends of the baby, tuck the baby with hands rather than stroking or patting, which is very common in our culture. You pat the baby, but actually when you pat the baby, it's not as comforting to the baby as you hold the baby together. And of course, as I think Junaid pointed out in his talk, as caution should be taken when changing diapers. Don't lift the baby's leg up, because that will affect cerebral blood flow. It's much better to change the baby gradually without lifting the legs right up to the sky. And if possible, if one person cannot do it, then try and see if you can get another person to help. This goes without saying. I mean, it goes without saying, we need to reduce stress. Stress, whenever possible, affects the neurodevelopment. We need to minimize the intensity, the duration, and the physiological cost of pain. Because remember, particularly the last trimester of pregnancy, and this is what we're talking about, a term infant now, or a near-term infant, is a time when every experience, a fetus or a newborn, whether the fetus is in utero or ex utero, either enjoys or suffers, is transmitted to the growing brain and may result in permanent structural changes to the brain. And this has been shown by Fernandez and others doing repeated scans on babies who have had pain or stress provided, and they can see that these changes become permanent and stay permanently. Unfortunately for us, and this is a recent study about 2 years ago, that we still continue to do a huge number of procedures in a baby. And sometimes you forget the count, but there are a large number of procedures done, and a large number are done without any pharmacological measures to relieve pain or to help the baby reduce the experience of painful procedures. And therefore, you should provide comfort in doing all procedures, whether it is minor, like changing nappies, because the baby doesn't change nappies in utero. So it is important that the very fact of just changing nappies is stressful for the baby. And the best way to do is non-nutritive sucking. But remember that the pain relief and the stress relief of non-nutritive sucking only lasts till the baby is sucking. And it is perhaps best, if possible, to do the procedures while the baby is being breastfed, or at least given some milk which contains breast milk, because the breast milk itself and the smell of breast milk reduces the stress in the baby. Recent work, network analysis of 35 studies still in press, has shown that non-nutritive sucking, breast milk or oral sucrose, has the most impact on pain relief and oxygen saturation. We need to protect the skin, and sometimes people think the preterm infant does not feel pain. Well, of course, neuroreceptors in the skin transmit messages about touch, pain, pressure, and temperature from 7 weeks of gestation, particularly in the facial and mouth area, and by the 20th week from the entire week of the body. And so the baby is born with neuroreceptors, and anything you do to the baby causes pain and stress, and one must be aware of that and try and reduce it and time it in such a way that you do all the procedures in one go when the baby is awake, rather than multiple times you come along, because that is the routine time to do things. We all know kangaroo care is very good, and I believe there is a seminar in Khyber Pakhtunkhwa next month about kangaroo care. It reduces mortality, it reduces infection, because it increases gradual increase in cerebral blood flow. I have already pointed out to you how important breast milk is and colostrum is, and we should be using colostrum, at least applying it gently on oral care, and promote non-nutritive feeding. Promote non-nutritive feeding even when we are doing gavage feeding. The advantages of breast milk, we all know. We don't need to elaborate, but now we have studies showing the enlightenment or the brightness when the breastfed baby versus compared to formula-fed babies, which is in blue, the breastfed babies in yellow, and that remains for years to come. That difference in trajectory of brain growth remains for years to come in babies who are breastfed. Junaid pointed out to caffeine, and caffeine is neuroprotective because as an adenosine receptor antagonist, it shows neuroprotective and repairing effect. And this has been shown recently by Martinez et al. Because caffeine blocks the A1 adenosine receptor activation, which causes the damage. And here is a diagrammatic view of that. It organizes the neurons much better, and so you get much less effect of the injury, which disturbs the neuronal formation. But there is also some work which needs to be repeated and needs to have much larger studies, because this is only about 50 babies or 49 babies, which is shown postnatal magnesium sulfate shows short-term neuroprotection, but this needs to be worked out. This needs to have a much larger study. Last but not the least, the parents and their role. They are the most important. It's their baby. And we sometimes restrict their entrance to the neonatal unit. Sometimes we limit their what they can or cannot do to the baby. We must acknowledge and support their understanding, not have them at a distance. We need to value the parents, and we need to use them to become competent caregivers, because that's what they're going to do when the baby goes home. And so we need to get these babies. Now, yes, there are studies, and these are shown here. This is a recent study which shows that the more educated the parents are, the better the outcome of the baby. But to start with, they all start at the same time, at the same level. And I just want to relate this story. This is a couple who had a baby born at 28 weeks, I think, in Multan, when I was teaching there for three months. And I had the honor of looking after and the pleasure of looking after this baby. And these parents who came from a nearby village, we brought them in, from the very beginning, and the mother stayed. The father came every day, and we taught them the care of newborn babies. And then when the baby was discharged, and they heard that I was visiting Multan again, they brought this baby like this to show me how the baby has grown. And that is the best reward one, as a neonatologist, one can get. Now, you need to create you all work in neonatal units. You need to create a healing environment. Parents are the key for that. But you need to also remember the baby has a taste and smell, and the mother's smell, the mother's touch, and the mother's holding the baby are much more soothing to the baby and much better for the brain growth than anything else you and I can do. It's a great interesting how mothers and grandmothers looked after our preterm babies in the villages, and now we tend to hand them over to doctors and nurses. We need to avoid loud noises. Anything above 45 decibel increases cerebral blood flow, increases the risk of IVH and causing harm. And I think it is important that we need to have parents-administered therapy. We need to teach them the posture. We need to teach them gentle physiotherapy. We need to teach them how to feed the baby. We need to teach them how to hold the baby. And this is what I have told you. The bundle does not need money, does not need expense. It can be done anywhere, and you can take one item at a time and see how you can do in your unit. This is from a Canadian study which introduced the neuroprotection care bundle, and they were able to, over a period of time, reduce mortality and severe brain injury. So, ladies and gentlemen, to summarize, autogeny of brain development is a dynamic process and starts early in gestation and continues long after birth. Brain development and its shaping are vulnerable to many internal and external insults. Whilst our diagnostic precision has improved dramatically, many of our practices do not pay adequate attention to the developing brain. Over the years, preterm survival and neurocognitive morbidity has improved, but long-term neuropsychiatric outcome has not changed. Feeding mother's breast milk, reducing painful experience, providing a conducible environment offers the best form of neuroprotection. And the bottom line is that our ability to facilitate brain development and prevent harm is real. We can do that. But to implement these in clinical practice requires deep knowledge of the multifactorial issues that impact brain development. And I end with this slide. Nature gives us the brain, environment turns it into mind. Remember, all care is brain care. Thank you. I'm happy to answer any questions.
Thank you so much, sir, for such an enlightening talk. And I would like to ask participants to please comment and ask questions if there are any.
Faraz, if there's nobody else in the queue, can I jump in, Dr. Rashid?
Sure, sir. Sure, you can comment, sir, please.
Okay. Thank you, Dr. Haq. Very, very, very good presentation. And obviously going to the basics of pathophysiology and everything and understanding different aspects. Would you care to elaborate to the audience that, and I don't want to sway away from the original talk, that what we do as neonatologists, besides all these things that you have already mentioned in terms of managing oxygen saturation and targeting a certain CO2 levels, and why we do and how it can affect brain. I'm hoping that somebody talked about it in the past, so I don't want to be repeating everything, but I think it would be good if people hear it from you, that how it may affect the brain. Thank you.
Nasser, as you know, neonatology, as you very repeatedly and often point out, is a passion. And of course, remember that everything affects the developing brain. High oxygen, low oxygen, high CO2, low CO2, all will affect, because there is a huge connection with, and I mentioned briefly but did not elaborate on it, because there is some very good work on neurovascular development, where how the blood vessels and neurons act together. And if you provide in the blood vessels high oxygen or hypoxia, or you provide high CO2, it will affect the neuronal growth and brain. So none of these things. The question always comes along as what levels are high and what levels are low, and that we can debate from time to time. But often those levels are debated, but not their consequences.
Hello.
Hi, Sajjad. Assalamu alaikum.
Assalamu alaikum. Assalamu alaikum, Professor. How are you? Thank you very much. I just wanted to say it was a brilliant presentation. And I learned a lot today. And I think each one of your slides needs an hour to understand. You have done such a lot of hard work in presenting everything and putting everything together.
I'm sorry that I made the slides complex. So I thought I'd try to make them as simple.
No, they were not complex. Actually, each slide in itself was a 1 hour lecture. But it's brilliant. You put all things together, and it's so nice to listen to you and learn from you. We have always been your student.
Thank you.
Thank you very much. I appreciate that. Thank you.
Very grateful. Thank you.
Thank you.
I would love to have some younger colleagues ask questions, because it is actually meant to, the talk is meant to explain to the younger colleagues on what we do and what we don't, and how it affects the brain.
If any other person have any questions.
You know, for us, some of my colleagues in Pakistan would know that my standard saying is that if after 45 minutes or 50 minutes of talk, there are no questions, either the talk went above the head of everybody and was useless, or it went below the head of everybody and everybody knew the fact. So it's very sad that the questions are not asked.
Dr. Huck, I'm going to jump in one more time. Okay.
Sure.
So I'm going to go back on your slides, and it's a passionate topic for me, the autism and everything. You know, like the behavioral issues.
Yes.
And you mentioned in some of your slides association between prematurity and autism. Now, question for you is that are you aware of any study where the babies who ended up developing HIE, mild to moderate, have in long terms have any association with autism? We know they have cerebral palsy, which is a completely different thing. But autism itself, have you seen any association in between it and HIE?
Yeah. Nasser, you know much more about, I know that you know much more about autism than I do, for various reasons. But no, I'm not aware of that, but I do not follow HIE literature in that great detail. So Sajjad may be able to answer that. I do not know. Sajjad, can you answer that? I think, has Sajjad left?
Let me check. Dr. Sajjad?
Yes, I do not see Dr. Sajjad in there. Yep.
Oh,
He's here.
he's left. But I honestly, Nasser, I do not know, but I don't follow HI literature in that depth. So I'm sorry, I can't answer your question.
Thank you, sir. Thank you.
Sir, can
There
I
is
ask
one
a question?
Sure, sir, sure, please.
जी सर, always very fascinating talk. आपको मैं तो बहुत अरसे से, and there are so many of my residents today जिनको मैंने स्पेशली कहा था कि सर की टॉक सुननी है, and I'm glad and I'm thankful to them also कि वो यहाँ हैं. I can see many of them here. अच्छा, if you've listened to yesterday, day before yesterday, Newborn Brain Society का जो webinar होता है every Thursday, there was a guy who came up and उसने बगैर evidence के, without any evidence, मैं आपसे पूछना चाहता हूँ, is there any evidence for it? Lot of neurocyticals, pharmaceutical type उसने word use किया है, neurocyticals, choline or vitamins और इस तरह की. Is there any evidence for it?
No, I attended that talk as well.
Yeah,
no.
I think he came up without any evidence और बड़ा उस पे जोर दे रहा था सारा, and I thought so there's no evidence. I thought you might have some idea about them, so there isn't any. Thank you.
No, there is no evidence for that. I attended that talk too. I listened to it. There is no evidence for that.
There's no evidence for that. ठीक है. So kind, sir. Once again, amazing. Thank you very much. Amazing.
Thank you.
There is one
Dr.
question in the
Hafni,
chat box.
Yes.
एक और point, sorry about that. I'm jumping in. The point that you raised, Dr. Huff, was very valid, that whatever we give to these babies, even the minor things like we think, okay, 7 days of antibiotics or furosemide, everything can affect brain. So I think that's even the anti-seizure medication that we continue. So I think that is an important message that I think everybody has to be aware of. But yeah, Dr. Huff, please comment further on what you think.
Absolutely correct. Absolutely correct. I mean, we often do not think of the brain when we prescribe any medication. We must think of the brain, what effect it has on the brain. And so we must be very careful in what we prescribe, the duration and the dosage, and what are the other variables associated with it. For example, the recent study on gentamicin, furosemide, and vancomycin has shown that if the baby is jaundiced at that time, the frequency of hearing loss goes up. So these are other associated variables which we must also take into account rather than just the drug itself. There was somebody, a younger lady colleague was asking a question which I didn't hear.
Yes, sir. There was one question in the chat box by Dr. Alia Bhatt. She's asking, do we expose low birth weight babies to infection while we are involving parents in an ICU in developing countries like Pakistan?
No, I have no evidence for that. If you maintain good hand washing and good hygiene, there is no reason. I mean, if you tell the parents that, look, if you touch the baby with the dirty hands or dirty things, your baby will be harmed. Which parent would harm their baby? No. That's why I gave you the example of that couple which came from a village near Multan. They were brilliant in the care of their newborn baby. They made sure that the nurses washed hand. They made sure that the doctors washed hand. So I think the parents, we underestimate the parents. We really do underestimate the parents. We must not. We must not.
Definitely true, sir. The involvement of parents is very crucial in the care of every baby who is admitted to the ICU.
Bilkul. Absolutely. Okay.
So if there are no any questions, we'll wrap up our session.
Thank you so much.
We'll be joining next week for the last talk of our neurology module. Thank you so much, sir.
Thank you. Welcome. Welcome. Thank you.
Yeah. Thank you very much.
Thank you.
Assalamu alaikum.
Assalamu alaikum.